Okay, so for the focused neurologic exam in patients with falls, certain of the components will be very consistent and similar no matter what we're doing in terms of any type of neurological evaluation, but we'll make some comments about things to look for in the patient with gait unsteadiness and falls. So initially, again, with mental status exam, you'd be talking to the patient, assessing their level of alertness, assessing orientation. You can do a quick screen of short-term recall and also their ability to follow commands, which you'll gauge as you're talking to them throughout the exam and as they follow commands and what you ask them to do. Then we would move to the cranial nerve exam. So again, we would start by checking the pupils and have you look straight ahead. And again, we're comparing both sides, looking for the direct and consensual response. And then depending on whether the patient has actual visual loss, you would then include the fundoscopic exam and also visual acuity. And then cranial nerve 3, 4, 6, again, we would look at my finger and keep following it, keep the head straight ahead though. Look up, down, and down this way. Okay, good. And then we would move to cranial nerve 5 for facial sensation. And again, tell me, do you feel this light touch on both sides?
Yes.
Feels the same on both sides?
Yes.
Okay. And for cranial nerve 7 again, we would have you close the eyes, open, and lift the eyebrows up. Good. And smile. Okay, good. So we're looking for any asymmetry of the face. And again, you want to take note of that. For cranial nerve 8, again, tell me, do you hear my fingers on both sides?
Yes.
Mm-hmm. Cranial nerve 9 and 10, we would have you open the mouth and say ah.
Ah.
Okay, and we're looking to see if the palate elevates in the midline, which it did. Cranial nerve 11 would be shoulder shrug and neck rotation. So ask you to lift the shoulders up. Good. Turn the head this way and this way. Mm-hmm. And for cranial nerve 12, we're assessing the tongue. So we would have the patient open their mouth, stick out the tongue, and we're good. And we're looking for whether the tongue deviates to one side or the other, and also if there's any signs of atrophy, or you can comment on fasciculations, that type of thing. Now, one thing to keep in mind when you're checking the cranial nerve 3, 4, 6, extraocular motility, you want to see if there's any signs of gaze paresis, because sometimes that can be seen in the setting of Parkinsonism, and of course that is associated with gait difficulties. So for example, limitations with upward gaze are common with something called progressive supranuclear palsy, and so you want to look for that. Then we would move to the motor examination, and again we would be assessing muscle bulk in the arms and legs, so that is why you want to have the patient in a gown. And so we're looking to see if there's any signs of atrophy in the muscles, which there isn't, and we're checking the arms and legs. Then we're going to be checking coordination. So again, we would have you hold both hands up like this and close the eyes and touch your nose with this finger, and now this one, and open them. And we're looking for signs of dysmetria. Now the other thing we can check would be coordination in the lower extremities. So we would have you take the heel of this foot, touch it to your knee, and slide it down. Good. And try it on the other side. Good. And then we would check fine motor movements in both hands. So we would have you take the thumb and forefinger, tap it together as fast as you can, and here. Good. And we're looking to see whether there's any asymmetry. If there's signs where it's slow and difficult for the patient to do this, it can be a sign of upper motor neuron dysfunction, for example, or also arthritis. So take note of any asymmetry that you might find. Then we're going to be checking strength in the upper extremities. So we'll have you hold the arms up like this. Check proximal arm strength first. Don't let me push the arms down. Good. Now hold them like this with the elbows in. And check each arm individually. Pull the hand toward you. push out toward me. Same thing here, pull toward you, push out. Good. Hold the fingers open. Don't let me push them in. And same thing here. Okay, good. Relax. And now we'll check strength in the lower extremities. So first would be hip flexion, and we'll have you lift the knee up toward my hand here. Good. And try it here. Okay. And then quadricep strength, have you straighten out the leg. Good. And this one. Okay, good. And then we could also check dorsiflexion and plantar flexion of the foot. So we would have you bend the foot up toward you here, and then push down. And again, compare both sides. The other thing that's important to include in the assessment of falls is tone. So, for example, you could check movement in the arm. We're looking for cogwheel rigidity as one of the signs of Parkinson's disease. And as part of the motor examination, you also want to assess for any signs of tremor, too. The tremor can occur at rest, which is what we would see with Parkinson's disease, or it may just occur when you have the patient hold the hands out stretched. So again, tone and looking for signs of tremor, all important for the evaluation of falls and gait disturbances. Then we move to the sensory examination. And again, with the vibratory fork, we can also check with temperature sensation with this and compare both sides and ask the patient, does this feel cool?
Cool.
Does it feel the same on both sides?
Yes.
And you can check distal to proximal, both sides, and try to localize any areas that the patient may say where it doesn't feel the same. And the same type of thing in the lower extremities. Start with the feet, compare both sides, and move up. Vibratory sensation can be checked in the forefinger. Check the distal aspect most. Do you feel that?
Yep.
And compare both sides. And you would also check in the feet. You could check the big toe first.
Yep.
And if they don't feel there, you could try, for example, the
Oh, yes.
ankle or even the knee. We then move to deep tendon reflexes. So you would check bicep strength, brachioradialis, check both sides. You could also check triceps. Then patella, have the patient relax the legs, make sure they're not placed on any stool. You want to have them hanging freely. And then for the Babinski test, touch the bottom of the foot at the ball of the foot from the heel up, and then you're looking for signs of upper motor neuron dysfunction. A positive Babinski would be dorsiflexion of the big toe. And now we would move to the gait assessment as the last part of this examination. So the next part of the examination is the assessment of gait and balance. So the first thing we'll have the patient do is stand and not hold on to anything and just stand in one place, and we want to see whether the patient can maintain their balance on their own. Then we can proceed to the Romberg test. We would have you look straight ahead and close the eyes. And just hold that for about 5 to 10 seconds, looking for any evidence of swaying or loss of balance. And open the eyes. So that would be a negative Romberg test. Okay. Then we would have the patient walk, and we're going to be assessing different things, including the stance, how much distance they have between the feet, and also whether they can actually walk in a symmetrical fashion. So we would have you go ahead and walk this way and turn back, and then try to get them to turn to the other side different times. So turn to the right and then turn to the left, coming back. Good, come back. And the type of things we want to look at would be the arm swing. For example, is there signs of reduced arm swing, which can sometimes be a sign of stroke. You can see it with other type of upper motor neuron disorders. You want to also see whether the patient has a need to hold on to things or other people in order to walk. The other thing we would look for are different patterns of abnormality with the gait. For example, with the Parkinsonian gait, you would see a shuffling pattern. With a person that had a hemiparetic gait, you would see more of a scissors pattern to the gait. And sometimes, very commonly, we see what's known as the cautious gait of the elderly, where it's a very cautious and slow gait. So one way to assess gait is to do the get up and go test, where the patient will then stand up from a chair on their own without holding on to anything and walk across the room and come back. Okay, good. These are the things we look for in assessing gait. We already talked about balance assessment. And just a few closing comments about the focused neurologic exam. You want to try to develop a focused and systematic way of doing your neuro exam, something that you do the same way each time. This will help you to remind yourself of the next parts of the exam that you should follow in sequence. It'll also help you to become more proficient at doing the neuro exam. And things that you want to be looking for, of course, you're checking for normal function and looking for any signs of asymmetry. And then you want to take note of that, because then that will guide you in further neurological assessment.